Yeah. We call it in Germany clicking.
Oh,
Clicking? Clicking. Yeah. It's really there are a reason for that?
yeah, because of the space is smaller, and then the oscillation is actually moving out and then click in.
And how can we solve
If
this?
you can make more space, you can actually increase volume.
How?
We can start with orthodox. But we need to get the right light, then we can
I need to degree the space. With orthodontics, the Invisalign,
we can use Invisalign, we use others.
because I'm working in Invisalign.
Okay, then I use Invisalign. Wonderful. We share information.
Thank you. Nice to meet you.
Someone will go down to bring in the bottles. Couple of bottles.
There is the director of the every time someone a lot of people. So today is for you. Yes, but I have a lot of people. It's interesting to know how the letters, the position of the rest position of the tongue, achieve. How you do it?
Again, let's say we get them to do some research and see whether they come out. We see how well they can handle it. If not, right, then we see the shapes of the teeth, of the whole arch, because there's a lot of posterior insufficiency.
This is what I but there is not data that connect this data with the other. So we have to know how, because if not, we cannot demonstrate.
So we need to do the research.
Yes, she said, maybe they say with echography.
But sometimes the teeth is actually so now using a single camera is good. So that's because there's most of the all these videos studied in Berlin. Berlin in Germany. Yeah, so they sing, oh, they sing, and they swallow. So it's all the action they do.
For adult singer.
Yeah. So, they have a collection of all these videos in different action. But I think more importantly is that I can share with you that video. You show him that yeah, at rest, this is how the tongue is. So if the tongue is like this, you can imagine the shape of the jaw would be different. If the tongue is down, the shape of the jaw is different. Easy to copy? Do you remember?
I have the lesson at 45. Every time she has something, it's for 5 years, that comes 6 years. It goes to the other lecture, my lecture, field lecture. It's there.
Yeah.
2 meters. 2 meters. You know?
Shall we? More to go, more to go. Okay. Mother.
Mada. M-A-D-A.
M-A-D-A.
M-A-D-A. Mada. Not yet.
We
Not
have
yet.
Mada family.
It's like, are we there yet? Mada.
It's totally different. We never know these things. Hardly matters we follow it or not, but it's a knowledge actually.
Helpful?
I mean, it's the knowledge. We never know that tongue is so important to our body. Nobody knows that.
Now I could tell you, in our history, culture, it does they talk about it a lot.
And I think so people who meditate, for them, so it's too important.
Yes.
Yeah.
I think now finally science has caught up to explain the ancient wisdom.
Yes.
You know,
Yes.
like thousands of years, right? Now you know why. Because this tongue up position has always been expounded in yoga and in Tai Chi Chi.
Yes. Yes.
You've always been telling us.
If you go by WhatsApp, you can get me on this. WhatsApp. So yep, can always drop me a note, then we can and maybe even form a group. We can always discuss this point. Okay, here we go. So as a dentist, we can optimize craniofacial structure for optimal airflow. I think that's the key. For everything else, we will do it well as well. We'll make you beautiful while we're at it. Okay? But we must have to have this as our end goal. Then you will know what you need to do and what you shouldn't do. Yeah. So this is also like I said, a few simple classification of the things to look out for. Got air, intake, orofacial structure, functional correction. We talk about myofunctional therapy as functional correction. I'll explain a little bit more. So we want to have this really big functional space created through functional orthodontics, prosthetics, of course restorative at times as well. Okay. Then when we are able to increase the inlet, as more air gets into the body, we're able to do this delivery properly to the cellular level. Okay, so when we talk about delivery, we're saying that you breathe in and out, right? Okay, what is an ideal length of a breath? How many seconds? Okay, 3 seconds is so within 1 minute you will do about 20 breaths, right? If it's 3 seconds. Okay. So what we try to do is to do 6 breaths per minute at guru level. Okay. 6 to 8. That means it's about 10 seconds per breath. Okay. So let me demonstrate how a 10-second breath looks like. It's easier if you partner it with some action. Alright, meaning like this. Okay, ready, go. Out. One breath. That's it. If I do it just like this, it takes a long time. That's why we do exercises and like Tai Chi and there's some other. You make it very simple for you to just take in that one breath and out. And even if we really look at it, how you stand, the pelvic floor position and all this will affect. I will go to it very quickly now. So when you can do that and you slow down your breathing. Okay, we'll wait for Dr. Song. Okay, so while we are waiting, we breathe. Okay, then my question to you is, which part of you are you using to breathe? Pardon? The lungs.
Not the day.
The lungs, not the diaphragm. Okay, so my point is this. Okay, it's interesting. The lung is a passive bag, right, that hangs there, right? So it is always the movement of our ribs and structures all around to create the volume. Then we have negative pressure as the air rushes in. So the bigger that volume that you can create, the easier you can breathe, or more air can suck in. And then the reverse is true. Okay? Bohr effect, B-O-H-R. Okay, everyone familiar with Bohr effect? Simply is that if you breathe in slowly, increase carbon dioxide, then switch your oxygen dissociation curve, remember that one? And it releases more oxygen from the red blood cell. Okay? So carbon dioxide, because most of us, we depend on carbon dioxide capnic centers, right? For detection of carbon dioxide level, then you regulate your breathing. Alright, so capnic carbon dioxide level is very critical in terms of regulation of breath. Then as you put in more oxygen into the cellular level, you can then create the outcome, energy, ATP. And you need red light therapy, right? Or naturally, the infrared inside the room, in the environment, will help you to enhance that. That's why last time we had all the bulbs, we have the fireplace. Oh, yeah, if we talk about fireplace, we go all the way back into ancient time. We all sit around the fire, right? That is your red light therapy, your photobiomodulation at that time. Yes. Then you have your movement, and your singing, and your dance. So all that makes you really healthy. Okay. So live like caveman, you'll be fine. Okay. So I think this is the point I want to highlight to you. Okay. So when we breathe, we actually depend on a few diaphragms. Okay. So it's being explained here 4. I'm going to argue that it's actually 5. So there is still the tongue diaphragm as well. Okay, so we have 5 diaphragms to help us to breathe. This is also discussed in the osteopathic manipulation. So there's these 5 diaphragms: tentorium cerebelli, the tongue, the thoracic outlet, thoracic diaphragm, and the pelvic floor. How? This is how. So on the top here, you have the tentorium cerebelli. So as you breathe, your osteopath can put their hand just right behind your head, and they can feel whether there's any restriction, left or right, whether your brain is doing. And there's a paper that highlighted inspiration, breathing in, is the driver for your CSF. Yeah, cerebral spinal fluid. Okay? And if you can breathe through your nose properly, you can create this movement. You have very good clearance of your amyloids right down to your BBB, right? And you can clear it out. If we have apnea, we can't clear our brain. That's why we have brain fog, dementia, Alzheimer, ADHD issues coming in. Right? So now there's also a recent research by MIT that if you use a 40 Hertz gamma wave kind of a vibration, right, you can help with the clearance at the BBB, right, to really clear your brain of waste. Better than any medication for dementia and Alzheimer on the market if you use sound frequency. That's why sound healing will be the next big thing that you should be looking at. Okay? So when you breathe, you see the movement of your thoracic, then you see your diaphragm, right? All this is not just to bring air into your lungs. They're also doing a lot of massaging, of your body. The truth is, we're not breathing air, we are circulating fluids throughout the body when we breathe, in that sense. So you use your body like an accordion. And then from the Chinese breathing perspective, you literally start from breathing in from the base. So you have to, tighten your butthole, okay? And then you breathe in and inflate your tummy. As you breathe, you should feel the air ascending, okay? Feel, right? Ascending through the back to the roof of your head. This is the in. So the in direction goes from the back up. It reaches the top, and then you release, it comes from the front. So there's a circulatory flow to this whole rhythm. Interesting, right? So it's just ancient art of healing, and then modern science, and then allied health kind of perspective. We're trying to all mash it together and see what goes on from there. So there's another study by Takashi Ono. Ono sensei in Japan actually did this. He connected to the breathing neuron of cat. Okay, and then from there he went on to connect to the phrenic nerve and also the tongue. So diaphragm and the tongue. And what he noticed is that they are moving in phasic movement. So every breath you take, the signaling is coming to your tongue as well. So your tongue is a respiratory organ. If he has extra electrodes and if you connect it to the tentori cerebelli, he connect it to the pelvic floor, he would have also recorded these few diaphragms working in tandem every time when you breathe. So I think we need to still pay a little bit more attention or time to understand breathing as it is. So the same thing, my niece, she's 12 years old, going through some before O level, so it's our school level exam. So how do we breathe? You have to answer, you use your lungs. If you don't answer that, you'll be wrong. So that's it.
Traditional answer.
Traditional. So that's why you can see we're integrating this whole idea of myofunctional therapy, or this recorrection of habits or functional habits, in order to create the kind of growth, the kind of alignment and growth at the same time, rehabilitation of joints and muscles, and also helping individual to sleep. And that covers really already a very big area. So habit correction includes your lips and tongue and swallow, chew and nose component. Okay, so myofunction, yes, there's many aspects to it. Next month, April, we're running a myofunctional course. It's actually organized by, we organized it in Singapore. We invited 3 speech language pathologists from Australia. Nada is heading the team, right, to come in to train us on this. Right, so there's a course, a 3-day course. That if you're interested to fly to Singapore, please come. Right, so it's very comprehensive. They are very good at this area, looking at from the very perspective of infant babies first, all the way to elderly as well. Right, how do we recalibrate the functional part? So yes, we have trainers who look at this. So I also do orthodontics without extraction, and I use this particular myofunctional component to create all this 6-axis growth and development, right? So that we can also get the volume right. So this patient is 16 years old, right? You can see really either it's an instanding lateral or it is excluded canine, whatever you see how it is. And obviously the lower teeth are very tight together. But after a period of treatment, about 3 years, this is where we are now. All right, totally non-extraction, but we can create the space and volume. Not only that, but I think I need you to see how when the tongue is in the position, right, it demarcates the whole centrality of the body as well. Right, it is, like I say, center of the lower jaw going up to the center of the upper jaw, it demarcates the center line. So if everything follows suit, that is where the center is. So sometimes you can check with your patient, whether the midline is correct. Is it? Yeah. Whether it is a tongue line, or is it the teeth line, or is it the jaw line? Because you have so many things that you want to calibrate to, which one do you follow? But I think the tongue is not going to, like, yeah, it's going to, like say, clearly mark it out for you. Okay? So back to this point, right, where this is the respiratory. So in Chinese culture, we talk about tongue up, 舌抵上颌, meaning tongue up against the upper jaw, right, for whole breathing. So you talk about the meridian line connecting at this position. So then your 气血会通, your circulatory system, your airway is open. Yeah, so they mentioned it long time ago, thousands of years ago. Then in the language, right, of like Tamil, Hindi, struggling with Sanskrit, right, the tongue position is also already very well discussed. And I would say I just don't know, but if you look back into your own history, yeah, probably they already mentioned it also. But one of the key points, like the several point, right, you have mantras, right? So like chanting, if you can do a certain chant, you become more intelligent, they say. And I think they're not bluffing you. Yeah, it's because when you do that chant, you're able to lift the tongue up to the right spot, and you create that myofunctional habit through the chanting. And you create the right rest position to allow you to breathe well and have good orthopedic position, and your teeth alignment is good, and your joint won't have clicks or clucks. Yeah. So I was in Sikkim a few years back. Sikkim is north of India, just at the border before China, right next to Darjeeling. Right, we went all the way up to 4,000 meters, and we're doing some work with Rotary, but to understand some foreign, far-fetched village, how can we provide medical care? But then we also realized we are also away from 3 hours away from real medical care if we go to that position. So it's really interesting. But in the monastery, which is huge, we were attended to by the 12th Zermang Chamon Rinpoche. Right? He is now the 12th reincarnation. You know, the reincarnation, they look for that person through all the clues that's left behind, right? Very interesting to pick up another child that is having all the qualities of the previous, right, leader, and then they groom that person to become the next leader of the monastery. Gave us this book on meditation, and it's also mentioned very clearly. 6 instruction explain tongue should touch the upper palate gently, a bit of space between your upper lower teeth, and your lips should be closed. Right. So one of the key points, many people encounter either headaches, joint pain, temporalis area is uncomfortable at the end of the day. They're always keeping their teeth together throughout the whole day. They don't rest with teeth apart. So can you imagine flexing your bicep once, flexing your bicep twice, 3 times, 4 times. One day you do 2,000 bicep flex. Every time if you swallow, try swallowing now. If your teeth are touching, you are flexing your masticatory muscle. Yeah. So some people have no other way, they don't know any other way, they just swallow with the teeth together. Yeah. So every swallow 2,000 times a day, they tighten the muscles and they create problems for themselves. So if you can, remember that swallow, just now we showed you, your tongue is up against the roof and you swallow cleanly. Now you have your myo spot still, everyone, okay? Hold against the myo spot and swallow towards the back of the throat. Very good. Yeah. One more time. Okay, so sometimes when you see some patient, if they're not able to hold that position, you see, yes, facial movement like this. Yeah, or they do this. Yeah, so they even blink, close their eyes, shrug their shoulder, move their lips. So what is going on? We learned about this word reverse swallowing, right? Actually, the word itself is correct. Reverse swallowing is correct. But we're trying to do it in a descriptive manner. We describe the correct swallow is this way, and when you push forward, it's reverse swallow. You know what I mean? It's too confusing. We should just call it, you should reverse swallow. and everyone would have got it right. But when you have tongue thrust, okay, if your tongue is not against the roof of the mouth, how can you swallow? You try, your tongue doesn't touch the roof, how do you swallow? Okay, so those people without the tongue against the roof, they will do their swallow by bracing against the teeth. So they either bite together, or they use the tongue and push against the front teeth, and they swallow. Yeah, so when they do that, of course, you get your AOB, your anterior open bite, or you can get salivation. So if you ask them a question, do you drool at night? They'll say, yeah, I will wet my bed, my pillow. So literally, every swallow they do is like this. If the mouth is open. So during the day, they can use the perioral tissue to hold back. So they have a double action. Tongue swallow, hold back. Tongue swallow, hold back. So if they cannot lift the tongue, they will bring the maxilla to meet the tongue. So that's why they drop the head. Yeah? So as long as you drop the head, the tongue can touch the palate, brace, swallow. Right? So then you see all this compensatory mechanism. And if you are able to give them like something like a myosport again, or I've tried other ways, but it's not easy. So myosport, brace against it, and sometimes I can demonstrate with my mouth open. I do this, tongue up against the area and swallow it. Yeah. So hold against the roof and reverse swallow. Reverse swallow. Yeah. Then it's a very complete way. So you need to rehabilitate that for the patient in order to get it all right throughout the day. So he also mentioned very clearly, lips and teeth should be in natural position, but lips must always close. Why do we need to keep the lips closed for all this to happen? Reason is really we need that volume. I'll explain that a little bit later in the last slide. So this is what's happening there in modern day. After breakfast, this couple walked out into the courtyard and start in the sun. Alternate nasal breathing. So in through the nose and then out to the other side. Then in through this side and out to the other side. So if you can do this every day, you won't complain that your left, right nostril is blocked. You know, your nose is very clear. Because you practice. The most important thing that is making you healthy, you don't practice. Then you complain to the doctor, I'm not feeling well. It's like, we never do our part. So if you breathe through the nose, there's this very nice gas called nitric oxide, NO, produced from your sinus lining. It is also demonstrated to be so effectively antimicrobial, So at the start of COVID, in Singapore, we had this very major spread through our worker dormitories. So I actually partner a professor from engineering, Dr. Umankan Katwa, which is a pulmonologist, a pediatric pulmonologist in Harvard. Dr. Rosala Courtney, a breathing doctor also from Australia, and we created this system where we just want the person to breathe through the nose, through an app to teach them the simple exercises to reduce down COVID level in the nose and hopefully recover faster. Yeah. So basically, after COVID, you can research NO and SARS viruses. Yeah, very effective against it. So this is your own defense system right at the center of the body, right? And we also know that if you breathe through your nose, you can reduce down the temperature of your brain through your sinuses by about 0.5 to 1 degree. Right? That also helps with the efficiency of your brain. And we talk about breathing properly, inspiration is also helping with that whole cranium movement and help with the whole clearance of the brain fluid. So this is the video.
La respiration totale me permet de retrouver une parfaite maîtrise de son corps. Elle permet de mobiliser les différents diaphragmes Le plus connu étant le diaphragme thoracique, mais aussi le
It's
diaphragme
French. I don't
crânien, le
understand it.
diaphragme
Emotional.
cervical et le diaphragme pelvien. Ces différents diaphragmes vont stimuler les niveaux, les plexus nerveux et végétatifs qui apparaissent à l'écran progressivement. Ces 4 diaphragmes, le diaphragme crânien étant une expansion ménagée que vous voyez apparaître ici, la foule du cerveau et la tente du cervelet, le diaphragme cervical étant constitué de la langue, des muscles susioïdiens et de l'osioïde, le diaphragme thoracique très connu qui est une séparation, une grande cloison musculaire qui sépare l'abdomen de la cage thoracique, le diaphragme pelvien, cette grande cordaie musculaire qui relie le sacrum aux os iliaques, aux os du bassin. Ces diaphragmes vont travailler ensemble
Yeah, so you can see the whole
et vont stimuler la circulation.
whole system works together, right, to pump.
Le diaphragme thoracique, vous voyez, c'est un muscle très intéressant, très important, va descendre à l'inspiration et remonter à l'expiration. Il va mobiliser les viscères, les intestins, le foie, le pancréas, la vessie, et ces viscères vont descendre à l'inspire et remonter à l'expire et vont
This is
stimuler
a psoas
le
muscle.
diaphragme pelvien.
Okay, very
Vous
important.
voyez la dynamique, la mobilisation de toute la colonne lombaire lors de la respiration.
So you move your whole pelvic floor.
Vous voyez ces viscères qui descendent lors de l'inspiration et qui remontent.
And it connects the diaphragm, mediastinum, and to the tongue. So it's the deep front line of the body.
Des viscères. Tous les muscles se mettent en action lors de la respiration, les muscles dans le dos, les muscles au niveau de la gorge, au niveau de la mâchoire, au niveau de la nuque, les côtes se mobilisent, elles s'écartent à l'inspiration, elles se rapprochent à l'expiration. Et pendant toute la respiration, les muscles abdominaux sont importants pour l'expiration forcée, mais aussi pour offrir une certaine résistance au diaphragme. Et vous pouvez respirer lentement dans le ventre et dans le périnée.
Yes. So we don't know the body well. Yeah, we don't know the body enough, right? It is really that whole, like say, the deep front line. So it starts from your toe, it runs up the sides, you go to your psoas muscle, you go to your diaphragm, your mediastinum, and all the way is down to your tongue, where it ends. So if you put your tongue up against the roof of the mouth, it has a very good support, like a muscular column in front of your spine. Yeah. So it has that whole function. Again, like I say, it's the breath, not only just simply, right? So even this is tongue posture, tongue movement, swallowing. Yeah, they do a functional MRI, and you notice that in protrusion and in elevation, right, you need more cortical activity to actually do protrusion. Truth is, we hardly do protrusion, right? Yeah, we don't need that in most action. So most of our tongue action is elevation, where we breathe and rest. And you can see it's a more efficient thing to do. So this patient came to me and the neurologist actually said she's an 8-year-old and she has Tourette syndrome. She has all this action moving, head is tilting non-stop. You see that, right? So that came to me and asked me, can I help? When a neurologist has given her the diagnosis and say that 60% chance of recovery only and no available treatment. So what I did was, this is the day of diagnosis, examination, and I'm just asking her to try her best to put her tongue up against the roof. So that is something that she's not used to doing, so she struggled a little bit with it. She did try to put her tongue up, but while she's doing it, you can see all this extra firing from the accessory nerve, from the facial nerve, right, is still happening. because the hypoglossal is not firing well. So why I say, look, okay, never mind, let's try again. And finally, she figured it out, and then she started holding her tongue up, Still at it, you can see she's struggling still. Struggle, try again now, tongue up. Actually, I can't show you her face, but she was smiling and looking at mommy and like, hey, how come I'm not twitching anymore? So I say maybe we have a chance. So we did all this myofunctional treatment. 3 months later, she's fully in control. She's no longer twitching. She's able to do all this exercise as well. Right? She's a normal child. Right? So sometimes pandas, Tourette, all that. Yes, it's cranial nerves. But what is happening? Now you can roughly get an idea. Get the tongue to work, and let's see where we go from. So the last stage of the whole, so we increase myofunctionally with the prosthodontics or orthodontics, the space and volume, breathe correctly from the breathing perspective, and then we pass the the oxygen into the cells, and now we want to use the red light photobiomodulation to increase the whole throughput. So we created this wellness center where we have the Novotor, and this is one way we can get our patients to experience this, a quick way to really recover, right? And there's also the other system where you can literally put a lollipop. So in the UK and I think in US as well, already photobiomodulation is good for oral mucositis, right? So, and I think Dr. Natish the other day, accident patient, he was doing a fantastic job with the. Without midi-chlorian, life could not exist, and we would not have no knowledge of the force. They continually speak to us, telling us that the will of the force. When you learn to quiet your mind, you will hear them speaking to you, right? So your mitochondria is your midi-chlorian, right? And yes, happened that Anakin Skywalker has, I think, 20,000 per cell, as compared to just a few hundred of thousands. That's why he's a Jedi, yeah, he used to be, I think. Okay, this end of part 1. What time is lunch, Professor?
1 o'clock.
Okay, so part 2 coming up.
Yeah.
And I have until part 5. So we see where we can, how far we can go and push this, right? Okay. Okay, tongue restriction, infant. So we know ankyloglossia, right? And of course it's still controversial how to diagnose, how to decide is such a difficult thing, right? Those of us who we are experienced, we see it, we want to release it, but we cannot just do it for every case. We work with our lactation consultant, pediatrician, and sometimes body worker. They are the one who also see the related symptoms. Yeah, then we can come in and have a look at it.
Please go back.
Yeah, nice. Brilliant.
So we sometimes face this problem of low tongue position, but it is not always restriction. Sometimes it's conditioning, right? So you give a habit of a bottle, a dummy, thumb sucking, right? All that can actually create this kind of conditioning that results in low tongue. So, you need this? Yeah. Okay, so we do see this in young babies. You can see no teeth, right? And they are presented to us having all kinds of issues. And one team from Stanford led by the late Christian Guilleminault. Now Zaghi and Stanley is really taking on the next round. Short lingual frenum left untreated at birth is associated with obstructive sleep apnea at any later age. It's a big, bold statement to claim, right? Yeah, if you're tongue-tied, you can't breathe. So after my first part of discussion, do you think this holds some water? Yeah, there's a possibility there. Alright? So now, how much of this is true, right? Normally at birth, the tongue is placed high against the palate. So they agree, such solo breath reflexes all with this up position. So a short lingual frenum then can create this suck and swallow difficulty, speech difficulty, mouth breathing, orthodontic impact, growth and development maxilla, and then sleep issue. So I think, you can see from this also now why he said all this inside this statement, right? There is a lot of impact. If the child can't lift the tongue from start of life, right, we're going to face all this growth and development issue that will lead on to breathing difficulties. So in the same study, 23 of the babies preterm, and they are put into NICU. They are given bottle. They are at it for 6 months, and after that they develop like hypotonic tongue, and their arch is smaller, and they even develop sleep disorder breathing because of using a bottle for 6 months. When we look at the babies, we look out for some of these symptoms from either the baby or the mother to understand that there's clicking, there's poor suction, there's breast drainage issues with it, can't clear it, baby slip off, poor weight gain. A lot of times it's a poor weight gain that's useful for quantifying the problem. So you can plot the situation, and if any intervention, the change in weight, can give you a say, hey, it's actually helping out. So this is how
latch-on affects your comfort. Let's look inside at the roof of a baby's mouth. Behind the baby's gums are ridges. Behind the ridges is the baby's hard palate. When your baby takes your breast into his mouth, if your nipple lands near the front of his mouth, your nipple will press against his hard palate. This is called a shallow latch, which can cause discomfort for you as he breastfeeds. If your baby breastfeeds with a shallow latch repeatedly, the friction and pressure may eventually cause you pain or even skin damage. Farther back in your baby's mouth, the palate changes from hard to soft. Some call the area near this soft palate the comfort zone. To get a better idea of where this is, use your own tongue to find your soft palate. When your baby takes your breast deeply into his mouth and latches on so that your nipple lands in the comfort zone, there is no undue friction or pressure as your baby breastfeeds. Latching on within the comfort zone is where breastfeeding is most comfortable for you and most effective for your baby.
So for the good latch, you want the breast to go deep in. Then the baby can lift the tongue, extract the milk, right? And everything is comfortable. But if the tongue is tight and restricted, the baby can't lift the tongue that effectively or isolate the whole movement. So what the baby will do is that as they lift the tongue, they lift the lower jaw. And because of that, you can imagine the baby is gumming mommy's breast all the time. And because they can't lift it well, they can't draw the whole breast into the comfort zone, they're feeding at the front end. And the breast is being pushed against the hard palate, and the lower jaw is gumming. That's why a lot of damage and discomfort. And you can see sometimes this kind of lip blister. If there's also a lip tie, the baby cannot flange. They need to flange to wrap around the breast on the top in order to provide a good seal. Then when they suck, there's good suction to draw the milk out from the breast. If the upper lip is actually restricted, the flanging is restricted too. The seal is insufficient. Every time they suck, there's also air leak. Sometimes end up with aerophagia. It means they eat a lot of air while they're sucking. And they get bloated up and they can create aerophagia-induced breast reflux. So they will get bloated up, enough pressure, then they... And in Singapore, we have this logo with a lion head with a fish body. It's an imaginary animal, but it's our tourist promotion board logo. It's called a Merlion. Okay? Yeah. So it's been spouting water by our riverside, and it's a tourist draw. So when we say Merlion, we mean you vomit. So the baby will Merlion after a while, after feeding, because of the pressure. Okay, so when we see this, I was so affected by one baby when I went for my training in Brisbane. The mom actually drove about 4 hours from inside Australia to reach Brisbane to see Dr. Marjan Jones. The baby is so swollen, I would say, here. But no choice. Mom wants to stay exclusively breastfeeding. This is the thing that the baby has to go through. The baby fought hard because the baby knows if I don't suckle, I will die. Right? And even with a bleeding lip, a swollen lip, I continue on. Yeah. So it's a very, very big struggle. And if we don't recognize this, But truth is, are we just doing it for breastfeeding? Is it just that? Yeah. So functional history, I mentioned earlier, you look into, like for example in the suck, like shallow latch, slide off, gumming, clicking sound. Click is like when the tongue goes up, the jaw comes down. Supposed to be isolated. Yeah, the tongue stays up, then the jaw stays down. But because it's stuck together, now they work together like a clockwork. The tongue wants to go up, bring along the jaw, but the jaw needs to come back and stay at the bottom to latch, and it brings the jaw tongue down. So it goes into this click, 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 click sound. Fall asleep because it's so tiring, extended feed because it's not efficient. Then the swallow component, they have a lot of drooling, now you understand? They swallow like this, rather than the reverse way. Yeah? Reflux, vomiting, colic, green feces. Yeah, then you have your breathing. You notice that they pull away the body, they feel very congested, they snore when they're on their back because the tongue drops back, like the first baby, remember? Then sleep episode, very short, very quickly they wake up, and you can hardly put them on the back. You have to do the football hole. They face down, over the shoulder, on your chest, tummy time kind of thing, right? So if not, you will face that they face a lot of breathing issues. So when we look into all this segment, we can then decide, this is my own matrix. There's still no like a unified matrix or a validated matrix that will be helping us to determine, right? Hopefully, again, the recent visit, or should I say the recent meeting over in Australia, more research is now being done in order at least to do evaluation. This point here is to highlight, usually I don't get the baby coming up from the street. Of course they come up, parents coming up from the street and ask me, can you do this, right? They're always generally referred by the lactation consultant or the pediatrician who believe that this is the right way to go. And they tried all ways and means to help the baby to breastfeed, and it's not working. That's why they think, okay, yes, I feel this might be the restriction. They can see it, but they try other way first. If they still can't overcome it, that's when the service provider, we will have to take on the role. Usually we'll still have to spend 1 hour being interrogated. So they bring the baby, we check, and then they will ask us thousands and one questions why we should do it in the first place. Can we do it any other way? Can we do it another way? So after we can pacify them, we bring the baby to the room. That's where things get really excited. Okay, so evaluation, check through all the forms, right? Discuss, because after you see the subsolo brief reflexes issue, you highlight to the mother what you see and discuss why it might help. So like I mentioned earlier, there are many other ways to determine pot lows, we have the Hazelbeckle and BAT, BTAT. Okay. Again, I say there's no standardized, but a recent paper that came through by Dr. Gehari helped with this understanding through a randomized control trial, feeding, tongue-tied release, test again, right? Control group didn't do it, test against the group, but later all the control group is also released. Yeah, no one is left behind. So it shows Dr. Yasuo Ito also presented quite a few papers, right? And long while ago you can see they already start doing this. So we examine the babies and we look at them, we see all this, we take photos, we're ready to go, right? And this is the time when we first started. We don't have such practices in Singapore at that time, 2016. So we invited the 2 lactation consultants, local, and I flew in the Australian lactation consultant, Jay, right, to treat a baby. All of us, 8, 10 people, all watching. Of course, the lactation consultants are the one handling the baby. I'm doing, my nurses is helping. We went through all this calibration for at least 2 months, every Sundays, right? So finally, my lactation consultant said, I can leave my baby with you now. Yeah. So at least then also my team members are confident enough to handle such a precious little bundle, right? To then do the treatment of tongue tie or lip tie release. So for here we have the protocol, and like I say, my government says or board says there's no protocol. It's already written. It's just that they didn't want to read it, right? So first thing first, how to make a baby cuter? Wear goggles, right? So swab that. Well, not swab, but swaddle them. Sorry, it's not swab. Swaddle. Let's change it now. I think I can't. Okay, no. All right, swaddle them. Swaddle, then give them a sense of 0 to 8, patient 12. I still remember asking Professor, right, what age group he usually work. Yeah, 0 to 8, thereabout. I remember older, even a 9-month-old, you can like push your handpiece away. That's
Yeah.
yeah.
Also before.
Also, yeah. So just 9 months, right? So definitely earlier, easier, and the recent discussion also, yeah, healing is much faster than the use.
I would like to stop.
Yes, go ahead.
Because this is my point, it's only my point. So my point versus all the points, the value can be very low. But we have to talk because you tell this. So 0 to 8 months. Okay, I can say 0. Difficult to say that we can do at 0. Because 0 is something that must be done at the birth inside the hospital.
Yeah.
So if the hospital are able to do, okay. But because the hospital don't do, we have to say that we have a gap between the birth and the real assessment after the mother, a couple of weeks, realized that she's not able to breastfeed. So we can say 1 month to when. So if the baby have problem to breastfeed, and he starts immediately to have problem, and the mother realizes after 2 weeks, sometimes after 1 month, that the problem is the tongue tie. Someone is asked to do the surgery, if we can call it surgery. In Brazil, there is a rule that says that we have an assessment in the first day and the second assessment at the end of the first month, so 30 days. So at 30 days you can, okay, what happened in this period, this 20 days, 30 days, that the child is not able to breastfeed? We don't know. Sometimes the babies arrive at 2 months, many times arrive to 3 months. Why? Because the mother are confused, they go on Facebook, they have a lot of information from one website, another website, one lactant consultant, another, and so they ask for something at 3 months. That for me is late. Why? It's late if the mother stopped for 2 months to breastfeed. So if the mother stopped at 1 month, 40 days to breastfeed, because the many problems, the ragazzi, so he don't feed, losing weight, and start the bottle feed. There is an indication, because then the issues that you have and we can have are related to an overtreatment if there is no indication. Is there any indication to the treatment at 3 months, 4 months? Probably there is no indication. So the problem exists, but the problem at the birth is only breastfeeding, possibly some air reflux, not other. We have not speech impediment, we have not postural problem, we have not airways problem, and the birth directly is something too much severe. We talk in general. We have not orthodontic problem, we have not development of the splacocranium problem at 3 months, 2 months, 4 months. So for me the gap is to work 1 to 3 months, 3, 4 months, and then jump to another age. Because when arrive to 9 months and you cannot work, because really it happened to me, 9 months she did like this. And so you have to force the baby. Yes, it's a play now. After, when you go with the laser in the mouth, it's not a play. And if we go back to my lecture 2 days ago, the memory of pain, we do not know if he maintained the memory of pain and this experience for the life or not. Because someone say yes, they forget. We don't know. Sure, they forget, but they remain here. And you know, the connections are so sophisticated in our body that sometimes can go back. So this point is very interesting to discuss, because we have to consider also the memory of pain. So I wanted to stop to talk about memory of pain, because you say correctly that the child, because now is baby, okay, they stop you to work. So you have to force to work. To fix the mouth, the head, to open the mouth, force to open the mouth. And it's quite a violence. For me, it's a violence. My point of view is a violence. Then you have to manage, for me, the problem later. Someday, some child is good at 5, some other is good at 6, Some other is good at 7, depending on maturity, the cooperation, the other characteristic, the behavioral component, the ability to react. That is different. That depends on the emotional status and the memory of body.
Thank you.
So,
No, thank you very much.
just to integrate,
Yes,
to give another point of view.
yes.
Well, I want to say something because sometimes you don't really detect the problem until we're 2 months old because the reflex integrate around about that time. So some babies they can eat well at the beginning because the mom had a lot of supply, and they just oversupply and they still not have a problem. But after 2 months, they go, oh, why is all the baby after 2 months they cannot do it, right? So there's a point that you have to go to my points. If they come in at 2-3 months, I still help them, but I prep them a little bit more.
So usually the situation is this. Okay, with regards of pain first, right? Really, consensus is there's no anesthesia, and sometimes they provide 2% sucrose water. Yeah, which is, I say, is better for the parents than for the child. It's nothing much, just sweet water. Okay, so when it comes to this early detection, we won't be in the position to decide. My youngest patient is 4 days old. How the lactation consultant in the hospital highlighted to her, and she sought my help immediately after she got discharged. Yeah, so we get that. And I think to your point, initially there will be hormonal assistance, right? So there will be let down, there will be the mom is easy to produce due to the hormonal help. Then it will come to a point where if there's always a physical restriction, then the child is not developing the ability. And from there, then it becomes a problem. They're not able to then start clearing the breast, and mother will start to feel it. Yeah, that's also when they start to realize maybe there's a tongue tie and we need help. We used to help all babies that come by, and even if they're not breastfeeding anymore, they use bottle. Then we realize the one with the bottle always will have recurrence of issue. It doesn't help. So we learned after a few cases, we are not going to help those with using bottle. They have to be exclusively still breastfeeding. Or else, no point. Just might as well just go into bottle feeding, and then we deal with it at a later age, like 5, 6, 8 years old. Yeah, because there's no immediate risk or immediate indication, because the feeding problem is over. They decided to move to the bottle. But if you want to stay with the breastfeeding, then yes, we help the parents out together with the whole team of support from lactation and even physiotherapists.
So you agree with me?
Agree with you. Yeah. Because
So the treatment 8 months is cool.
yeah, so some even at a 1 year age they come, but they're still breastfeeding, but mixed. They're doing mixed, but it's not that effective if they're not exclusive.
Yeah, and for the older baby, what I do is I really make sure that work with the feeding therapist or somebody know about retraining the function part to make sure that they can really benefit. Otherwise, we're really wasting the surgery time.
But the truth is, of course, again, what Prof say is the feeding. But we know behind the scene there's still the breathing, the swallowing, and all that, the neurological component, whether they can sleep well or not, it could be from that tongue tie. But there's not enough evidence to say that we're doing it for that. So I leave it at that for you all to just understand, but I'm not saying that it is the indication, right? But you know, behind we have so much more things that we have to deal with other than just the feeding. Okay. So of course, using the laser, the setting, and then finish 1 to 3, return to mommy, soothe the baby, usually breastfeeding. Interestingly, they talk about how to stop the bleeding, in a few cases. And one group from Indonesia, they are pediatricians. and they have been dealing with many babies for the past 8 to 10 years. So she said, don't worry about bleeding, just put it to the breast, breastfeeding, milk, done. Bleeding will stop. Yeah. So I think we have different perspective of how to do it. Because like they say, they don't have any other resources. So a pair of scissors are released, and then the baby has to fend on themselves, or the parents have to fend for them.
Sorry, back this one for the parameters. For the two that has the YCG, one is going sharp. 2.75, 75 Hertz. H mode or S mode?
H mode.
H mode.
Yes.
So the ablative mode. That means, one moment that they go to the, that means 275 divided 75, 36, 40 millijoules. The other one before was when you started, the first you did 1 point was 50 Hertz.
Which one for?
The first that you did with the picture with all the group.
Oh, this one.
Yes, was 175. Was 175 divided 50. That is the same. So he used just because at the end is a laser that is the master. He used the same energy. The first time using 50 Hertz. So 50 Hertz at 1.75 watt. The second time at 75. Is this one? Yes. At 75 Hertz. So increasing the Hertz. So increasing the power. 2.75. But the energy is the same. Okay? So you can understand that then his skill allow him to improve the power without changing the energy, because the energy is what we see is effective to cut. Then you can be slow or fast. So this energy, that is a low energy, delivery very fast, is more effective with higher power. And what I would like to say about water in babies is difficult to manage, because then go.
Understand. So we, of course, there's always a chance for aspiration, right? So when we deal with this baby, I always have 2 assistants. So I think that's also one way, and we control the water quite well. Again, it's not like just flooding the system, just really be mindful and finish or stop, let it clear, and then go again. Yeah.
Because these are the only intervention that when I use the erbium, I do without water. Because the mouth is this size. So with my finger, 2 fingers, so you need to put the tongue up, then you go with the laser. In this case, it's very good to have a straight handpiece, because you go only with the tip inside. Longer tip is better, because the handpiece itself hidden the visual, and so also the aspiration could be a problem. So a choice to work without water, because it's less than 10 seconds. Okay.
I've been to straight handpiece just a few months ago.
Oh,
Okay.
Yeah.
So you are.
Or you can say the diode is a better option or not? Diode?
Diode is an option, he will say. I will tell, but he will say no.
It is in the hands of a very good laser dentist. Diode is a very good tool, but anyone starting with this run the risk of thermal damage to the area, I feel. Yeah, and even the more senior user, we have one pediatric dentist. We occasionally see cases where you can see is due to thermal damage that the salivary gland is having blocked. So it's a risk. Too much heat.
You know, Phil Ham did the first module lecture. He works when he has not had a commitment with the brand, the company, or whatever. He prefers the diet and use the diet. But he works very well, very accurate.
Yeah. So even when one of my dentist colleagues in Cambodia, so he was just showing me how he do it for his older patient. So I can see very, very light touch, very quick positioning, right, to very clear the fascia. So you need that kind of like brush stroke hands, don't linger. Yeah, really clean it. So, but for the rest is much easier. So yeah, so you'll see, you'll be acoustic. The trauma actually on us as well, bro. The truth. When you deal with baby, oh my god. No, it's like, again, pardon my language, it's like your balls have to streak still, and you're going like, I'm going to see this baby now. It's always not walk in the park. You know you have such a big responsibility, right? Even though it's just 10-30 seconds, it's big responsibility.
You ready?
Now we're going.
But there's also a discussion whether they feel it or not. So we all have our experience. Some babies sleep through it. Yes? They sleep through it? Yes? Okay? Okay. So I say now we do rest. Yeah. So you can see once we finish with the upper, they just stop crying. So it's like, of course you're irritating him, you're holding him, you're spraying water in his mouth. Yeah. So you can see this is okay, it's helpful sometimes when they cry. And this is how loud they are actually. Go for it. 1, 2, 3, 4, 5. And you can always sometimes feel a pop. It's good and bad that I'm not doing this anymore. It's not easy. It's not easy, really. Yeah, but I'm glad that I actually have 2 good years with this. So it's that foundational understanding of the default setting of a human, right? And from there, I still remember going to my chiropractor and then she was like, "Hey, aren't you Dr. Yu? You treated my daughter, and she's fine now." Yeah. So knowing that you can do such a wonderful thing right at the beginning of life and preventing them all that issues later on in life, whoa, this is what we are capable of. Okay, for release, a nice diamond shape. Sometimes we talk about stretch, wound management, but it's more like not trying to just break the wound, but you're just trying to just say, get some movement going. And the best way is really like the baby going back to the breast, the suction. Yeah, that whole feeding is the rehabilitation process really. Then, yeah, these are the two papers. One by Phil Han and of course Professor, right? Can look into these two papers. Okay, so we have for children and adults as well. So similarly, we look at it from, sometimes yes, they have more now speech issues, right? So parents or teachers will come to us. I went to Estonia and my friend was telling us that this phrase you have to say something about the wheel of the train is broken, something along that line. And then you have to go to, and if you cannot do that, you'll be pulled out of class and you go to see the medical center. And they will then assess, tongue-tie release will be done. Then they have speech therapists within the school system to rehabilitate them. So language like English and Mandarin that we speak, sometimes we can get away with things. We are not so clear, but we get away with things. But if you speak Italian, can you? Certain words, Tamil, or maybe even Bahasa Indonesia, yeah, they have to all that. If you can't roll and thrill your tongue, yeah, you'll be caught. Yeah. So again, speech is one big component, but you can see short lingual venom, forward head posture, risk of. Now I think you can understand the co-relationship, right? Yeah. So how that whole tongue affects, and of course, Carmen Fernando, sorry. Yeah. Also wrote a book on tongue tie from confusion to clarity, about talking about all these components. Right, so yes, we do also occasionally see this that is more specific to just dental issue from a diastema. Of course, to get the young children to work to you, you have to anesthetize them, or else they'll run out of the chair quite quickly. I did my second tongue tie with no anesthesia, just to feel what it is like. So I would say 80% of the time I'm fine. When it goes into the fascia and all, occasionally few areas there's a zing, but other than that it's just still comfortable enough. Yeah. So for that, usually it's quite quick. After the surgery, they recover. Yeah, you can see the full freedom, and just a cotton roll will more or less stop the bleeding, and they're back at school, back at work. Right. So usually quite fast in also the recovery, a few days, and of course the diastema closure can be within a few weeks, 4 to 6 weeks. You can see sometimes the gap is already closed. This is
We eat and speak with them, but our tongues may be even more important than we think. In a condition called onchoglossia, also known as tongue tie, the tongue is tethered more tightly than normal to the bottom of the mouth by the lingual frenulum. While this is usually considered relatively harmless, new work from dental and sleep experts at UCLA and Stanford suggests tongue mobility is critical for proper development of the jaw and facial tissues. In the study, researchers evaluated tongue mobility in 302 patients using the tongue range of motion ratio and the Kotlow-free tongue measurement. All measurements were performed in triplicate to ensure consistency and accuracy. Each participant also had dental casts made and x-rays taken to capture anatomical features of the teeth, mouth, and face. Most people had normal or only slightly diminished tongue ranges, although some had more severe restrictions. Reduced tongue mobility correlated with a smaller ratio between the inner canine width and the canine arch length, which may indicate underdevelopment of the upper jaw. Limited tongue movement was also linked to having longer soft tissues at the back and roof of the mouth. Longer soft palates are common in people with obstructive sleep apnea. It's possible that people with reduced tongue mobility may breathe with their mouths open more, or swallow abnormally, which may help elongate the soft palate. The longer soft palate could also arise from reduced tension holding up the soft palate due to narrower maxilla. Contrary to previous suggestions, however, no association was found between ankyloglossia and position of the hyoid bone, a horseshoe-shaped bone in the neck that moves with swallowing, chewing, and breathing. The group also found no relationship between decreased tongue mobility and the classification of malocclusion, which 2 small studies previously reported. But the lack of evidence for these associations doesn't mean they don't exist. While this study is one of the largest of its kind overall, there were few volunteers with severely restricted tongue mobility or with abnormally aligned teeth, which may limit some of the findings. Nevertheless, the results do suggest the tongue plays an important role in development of the mouth and face, and if the tongue cannot move freely enough, people risk developing high-arched palates, a narrow upper jaw, and longer soft palates.
So when you go for your orthodontic lectures, sometimes when they take a photo of the lower jaw to show the teeth alignment, you cannot unsee this now. This Eiffel Tower right underneath. And you were like, oh my god, that's a very big tongue tie. So one of the key things is this buttressing, right? Sometimes I feel, you want to know whether this is restricted, you can look up for it. If you see this buttressing, to me is a case of restriction. Alright, you just have to deal with it. Of course, there are many ways to classify. One of the ways that they provide is using this tongue range of motion ratio, measuring when your tongue tip to your incisor papilla, when your tongue tip is up, full open, and then when your mouth is fully open, then you do the ratio. So to me, I have also just simply looking at this totally flat, you can your whole base of your floor of the mouth being able to elevate. Anything between the 50% mark and below, anything between the 50% mark to the tip and right at the tip. Right? So is this going to tell you the full story? No. Right? This is only physical. And we have individual that's like this, right? No restriction and can't get the tongue up because of habit. We also have a teacher, a Kung Fu teacher. She is this, all right? Right at the tip. But in order to perform Kung Fu and train the young ones, she's in her 50s, 60s, right? 50 plus, 60. She needs to put the tongue up to stabilize herself. Then she trains and she can do that. But the moment she relaxes, the tongue will just drop. That's why she always has a forehead and then she has a headache that she cannot solve. Of course, I tell her it can be due to a tongue tie. She doesn't think it's the case, so no choice. I can't help her. But that's also one of the considerations. So next to this is the linguistic. This is my little invention, right? So I added some in the first version is just a plain linguistic. The second version comes with some measuring matrices so that we can also use it like this kind of measuring tape or yeah. So this one you can check out the range of motion and also the coplo. Right. So for me, I use the tongue stick. Right. Also similarly this way to get a similar way of measuring ratio. We have the coplo. We have also other free range, shall I say, the free measuring indices. So it's helpful, like how I see it here. You can use for checks and evaluation. You can also use it for your surgery. Made of bamboo, it is non-reflective, so for laser it's quite effective or helpful. And most of my user will reflect that it is non-slip. Because of the bamboo, it's quite comfortable to hold it there. Plus, some young babies or maybe children, they don't find it so cold in that sense. They don't move away from it. And then my colleague, like Yuli, she's a speech therapist over in UK. She's the founding president of the British Society of Myofunctional Therapy. She came up with a new device now, quite similar to this. But initially, she was using the linguistic and using putty over it. So she shaped it so that she can use it for retraining purposes. Yeah. And Nada, she's also a speech therapist. Sometimes she works with some special needs children, and she will stick the lolly to the linguistic to actually help with the lateralization by attracting the tongue to the sweet spot, literally. Yeah. So I think it's up to your imagination. A lot of people are asking me for the instruction manual, but I just couldn't come up with one because I don't think that there's one. You can use it whatever way you want it. That's all I say. We'll pass some to all you later and bring it back to use. Right. Okay. So Dr. Zagi also played around with it for a while, and this is his paper, and it's an ongoing number that is because he's just recruiting all his patients into this survey, right? At the time was only 348 patients, but I understand it's now reaching into the thousands, right? So for him, he uses the scissors, but I understand that he's now using the carbon dioxide laser as well, right? So prep work before and after, most important. Then we go ahead with the treatment, and you can see from the patient survey, general improvement in many of the symptoms with very little complication. Then for him, he also came up with this whole guidelines, but I think to suffice to say is really make sure you do all your pre-testing, collaboration. Okay, we'll just go through. You can just take a photo of each. Right, time range of motion, measurement, understand the habituated compensatory pattern. Look at continuous contact, pre and post myofunctional therapy of the tongue to the roof, right? Then pre-operatively, we also want to assess all the muscle function, active parental involvement, also necessary. Right, 2 months after, continue to work out in order to achieve the right strength and pattern. Right, we can say malfunction often continues for 1 year or longer. Depends. Again, like say whether your patient is so committed to you, right? But I feel it's necessary. Like for myself, after 40 years of not lifting my tongue, even after my first release, I can't get to the optimal spot immediately, right? So I try my best to do my exercises, blah 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 blah. After 4 years, then I realized, oh, it's tight again. Yeah, because as you stretch, you now get to a new point that your previous healing only allowed this much. So I went for the second round, and now I'm another 6 years down the road. Yeah, I can feel my next level of achievement, and I'm ready for my. Who wants to do it for me? one patient volunteer. Yeah. So yeah, the guidelines. So anyway, you can find. So this is one patient referred to me after or he's doing orthodontic treatment, and obviously you can see, right? So this is the linguistic able to just go in to hold and assess, have a look. You can also use the other end to check on the throat, Malapati score or the tonsil scores, right? So now use this, nice and comfortable after the local anesthesia, then we can use that, and then here we go, and this is right into the mucosa area, right? And what I encounter is in our Asian population, we tend to see this vessel right in the frenulum. Any experience? Do you all see that vessel often too? Yes.
Yeah. So close sometimes to the tongue piercing.
Yeah.
So I feel really uncomfortable.
How about Professor? Do you, for the Caucasian population, do you get the vessel in that frenulum too?
No.
Oh, lucky you. Yeah. So we tend to see this
Vessels in the frenulum.
in the frenulum.
Mean capillary.
Oops.
Capillary.
I did it again. Oh. Yeah, the last
The
time.
problem is when the frenulum open and you try to achieve the diagonal of the side. So and you go lateral. Then you can meet the vessels.
So yeah, correct. For us, it's not the two vessels or the veins at the side, but it's right smack in the middle. Just a moment. So in order not to have a big pool of blood right in our face, we so we have to be very mindful of this vessel when we see it. Sorry. So as we go through this, I think what I like about the system is that it allows fine dissection. Alright? So going through, I can create this opportunity for me to cut through everything and leave that vessel right in the middle. So I have a chance to even do a bit of ligation first before I proceed further. Because if you cut right now, it's going to just.
So the middle is the vessel, the one
Yeah.
with the vessel.
Yeah. Do you see that?
Yeah, but I hardly see this.
So just cut through. So sometimes after this, you're still able to, you're not too worried really after you do this ligation. You can continue to attend to the rest of the fascia, cutting it through until you hit the genoglossal. Alright? And then I might want to leave it to the end because even sometimes through this ligation, there's still some bleeding. Alright? And you cut through, bang. Nice. Okay. So no bleeding, continue. Right? So after that last bit, then we will go ahead and release the. So I always love my laser for this purpose also, for stitch removal. Sometimes my oral surgeon, after he raise some flaps, right, to do augmentation and all, this kind of stitches is right at the sulcus. And it's so short that you know when you pull it's uncomfortable. Then I will pull out my laser and do my STO. Then you pick it up, patient don't even know that you remove all the stitches already. Yeah, but of course it's a very expensive tool to just do stitch removal. But since you have it, why not? Yeah, why not? So I think this also is a very classic case for me over the years. So this patient came asking me whether I can help out with his neck problem. Yeah, so it's not semi-straight. So of course I treat TMD, but you don't see cases like this all the time. And when we have a discussion, I look at it, I say maybe. So his colleague is wondering why is he seeing a dentist for this problem, right? Yeah. So well, since we're at it, we look into the mouth, and sure enough, you agree this might be restricted. Okay, so we did the preparation, release, and preparation after, and this is him 3 months later without any other different intervention. So in the video, he will also explain to you that he can open his mouth wider now. He can say his 3 syllables word. He can't do like appointment. He can't say appointment last time. Yeah, he has very limited vocabulary because he can't do words like this. And he can finally yawn. He will tell you that I can't yawn, and when I see people yawn, I am jealous. Oh, unfortunately, that's his life. But thankfully, all this changed it, right? Just a tongue tie release. And of course, now his colleagues asking him, like, who is your dentist? Right? What would we do, right, to actually get this going? So I think you can clearly see the relationship now, right? How the tongue, the fascia, the orthopedic condition, whether you need to compensate for breathing, your head and neck position will then do the necessary adjustment. So this is very important to understand that the AOJ is involved as well. So,
what was the transition time from
3 months. 2 months.
2 months? 8 weeks. Combination of other.
No. So he tried everything else. Then finally they said, okay, maybe my website say neck problem, right? So he came neck problem. See whether I can do it. Yeah, that's it. So I'm like, well, you have tongue tie, I'm not going to treat. Of course, I got into trouble for this. I gave a lecture in Malaysia, and this, immediately I finished lecture, my dean was in the audience. He received a phone call from someone who, and he came and put his hand around my shoulder and said, wow, you're doing back treatment now. Is that fast? I woke up with it. I mean, my dean, he didn't attend my lecture, and he still managed to get a phone call. Somebody complained to him already, and then he called me. So this is cute, right? So you watch. In Japanese, right? You say, can you reach out to the key? You say, just a few mm more. Look up. So this guy say, I can reach it. Just hit it and it will come to me. If you stick your tongue out, you get more extension. The next time when you are at the car park, you can't reach the ticketing machine, stick your tongue out. You'll get that. So. Is it true?
Can try.
You know Michael Jordan?
Michael Jordan.
So he wanted.
Yeah, sticks his tongue out most times.
Yeah, it's true.
Without knowing.
So when the tongue is in the right position, your extension, okay. I think very simple test again. Just sit and you turn your head to your left or right. Slowly. Yeah. Do you feel any restriction? Left side or right side? You know it yourself, alright? Okay. Now you put your tongue up to the roof of the mouth. Hold it at the back. Now you start turning again. It should be, the range of motion has improved. Yes, no?
Yes.
So when the tongue is up, your whole neck extension, then you are into neutral, and then it's easier to turn. Rather than when your tongue is down and your cervical spine will collapse, and then you get restriction in the whole. So when your tongue is in position, your whole spine is extended. Then your vestibular nucleus and your trigeminal nucleus will talk to each other. No compensation, your body is free to move. Yeah. Okay, part 3? Or shall we break first? Prof, what do you think?